dietary intake. So for all of these reasons, the urinary findings are highly variable. So in clinical practice, the way you diagnose hyponatremia secondary to diuretic therapy is to discontinue the drug and see if it improves. Now let me explain why thiazide diuretics much more commonly cause hyponatremia compared to loop diuretics. Recall that loop diuretics block sodium resorption in the thick ascending limb. This means that more sodium will go to the collecting duct and therefore go out in the urine. It also means that the osmolality in the collecting duct will be higher and therefore less water will be drawn out. However, there is a second effect of loop diuretics that you need to always remember, and that is that when you administer a loop diuretic, you diminish the osmolality out in the medulla. The pump that is inhibited by loop diuretics is responsible for maintaining much of the high osmolality out in the medulla. So when it is inhibited, the osmolality in the medulla falls. This means that you have a much lower driving force to remove water from the collecting duct, and this is why loop diuretics are such powerful diuretics. They send lots of water out in the urine. What this means is that in the setting of a loop diuretic, it's very hard to reabsorb too much water and become hyponatremic, and that is because these gradients have been diminished by the drug. Contrast that with thiazide diuretics. In patients taking thiazide diuretics, sodium resorption is blocked in the distal tubule. This means that the osmolality in the collecting duct will rise, more sodium goes out in the urine, and there is slightly less water that is resorbed. However, thiazide diuretics leave the medullary osmolality completely intact. This means that patients taking these drugs continue to maintain the ability to absorb lots of water. This is a setup for hyponatremia. You're sending sodium out in the urine, but your ability to reabsorb free water remains intact, and thus the tendency to develop hyponatremia is much higher in patients taking thiazide diuretics. I've summarized these points on this slide. In patients taking loop diuretics, the medullary gradients are diminished. This makes it difficult to reabsorb free water, and this is why loop diuretics are powerful diuretics. This also means there's a low likelihood of resorption of excess free water leading to hyponatremia. Contrast that with thiazide diuretics where the medullary gradients are intact. This means the nephron has an intact ability to absorb free water. More sodium will go out in the urine after administration of a thiazide diuretic. This is responsible for its diuretic effect. However, there is a higher likelihood of resorbing excess free water because those medullary gradients are intact, and thus a higher risk of hyponatremia seen in patients taking thiazide diuretics. A third group of causes of hyponatremia are those related to high ADH levels. So for starters, any cause of dehydration can lead to low intravascular volume, and this can stimulate ADH release from the posterior pituitary. So for example, patients who have vomiting or diarrhea or patients who are sweating a lot can have high ADH levels. And as we talked about before, when the ADH level is high, the sodium level varies with water intake. So if you take in lots of free water, this can lead to hyponatremia. And this is one of the reasons that athletes drink Gatorade instead of water, because Gatorade replenishes not only the fluid that they've lost, but also the electrolytes that they've lost. Adrenal insufficiency is a well-described cause of hyponatremia that works via high ADH levels. I talk about adrenal insufficiency in detail in the endocrine modules, but for our purposes here, cortisol normally suppresses ADH release. So the loss of cortisol in primary or secondary adrenal insufficiency can lead to high ADH levels. In addition, in primary adrenal insufficiency, there's also a loss of aldosterone secretion. This can lead to salt and water loss through the kidneys, and that can raise ADH levels by depleting intravascular volume. Hypothyroidism is also a classic cause of hyponatremia. It's believed to be related to high ADH levels that occur when thyroid hormone levels are low. And then a final cause of hyponatremia related to high ADH levels is SIADH, so let's talk about that now. SIADH is the syndrome of inappropriate antidiuretic hormone secretion. In this syndrome, too much ADH is released inappropriately, that's how it gets its name, and this leads to hyponatremia. In this setting, the urinary sodium will be high, usually greater than 40 milliequivalents per liter, and the urinary osmolality will also be high, usually greater than 100. And both of these findings should make sense to you. The urine is being concentrated because ADH is inappropriately elevated and free water is being reabsorbed by the nephron. Importantly, if you want to make a diagnosis of SIADH, you have to exclude all other causes of high ADH, such as the ones we've talked about in the last few slides. So you can't make a diagnosis of SIADH in a patient who has heart failure, cirrhosis, dehydration, or thyroid and adrenal disease. All of these things have to be excluded before you can say that a patient has hyponatremia due to SIADH. There are a number of clinical scenarios where SIADH is commonly seen. The first is in association with certain drugs. There's a long list of drug causes of SIADH. Two of the classic ones are carbamazepine, which is a seizure drug, and cyclophosphamide, which is an immunosuppressant. SIADH can also occur as a paraneoplastic syndrome, especially in small cell lung cancer. Certain cancers like small cell lung cancer can produce ADH and lead to SIADH. Many different central nervous system diseases stimulate ADH release and lead to SIADH. This can be seen with strokes and brain bleeds and brain tumors. And then finally, pulmonary disease of just about any cause can also lead to SIADH. The mechanism of this is not entirely clear. Now, you would think that in patients with SIADH, they would appear fluid overloaded on clinical exam, that they would have crackles in their lungs and lower extremity edema, all from the excess fluid the kidneys are retaining. However, it turns out that in patients with SIADH, they have a normal volume status when you examine them clinically, and it's very important that you understand why this is the case. So in SIADH, there is fluid retention due to high ADH levels. However, the body responds by dialing down the renin-angiotensin-aldosterone system. The lowering of aldosterone levels leads to more sodium going out in the urine. This worsens the hyponatremia. However, the lowering of the aldosterone levels also decreases the water reabsorption by the kidneys, and this prevents patients from becoming fluid overloaded, and that is why patients with SIADH have a normal volume status. So a classic question on rounds in the intensive care unit is to ask medical students or interns for the diagnostic criteria for SIADH. So I've shown them on the screen here so you know what they are. So first of all, you have to have hypotonic hyponatremia, meaning you have to have low plasma osmolarity and low sodium level. You have to have normal liver, renal, and cardiac function, so you exclude these organs as causes of the high ADH level. There has to be clinical euvolemia, meaning an absence of signs on physical exam of volume overload. Thyroid and adrenal function must be normal, and the urine osmolality must be concentrated, meaning greater than 100 milliosms per kilogram. The treatment you will most commonly see employed for SIADH is fluid restriction. Remember what I told you before, when the ADH level is high, you retain most of the free water that you drink. That's how you can become hyponatremic. However, if you restrict the access to free water, then the sodium concentration will slowly rise over time, simply because you are taking in less free water. There is, however, a special treatment option for SIADH that's sometimes used. That's dimeclocycline. This is its structure shown on the screen. It's a tetracycline antibiotic, but it is also an ADH antagonist, and thus it can raise the sodium concentration in patients with SIADH. Our next cause of hyponatremia is psychogenic polydipsia. Your kidneys can excrete a lot of free water. However, there is a limit. If you drink more than 18 liters of water per day, you can develop hyponatremia because your kidneys cannot excrete all of this fluid. And this occurs in psychiatric patients who are compulsive water drinkers. They become hyponatremic, and importantly, their urine osmolality is low, less than 100. This indicates the kidneys are working. They are trying to eliminate the free water. The problem is that the patient is drinking more free water than the kidneys can handle, and it's very easy to fix this problem. You restrict the access to water, and then the hyponatremia will resolve. There are a couple of special diets that can lead to hyponatremia, and the common theme in all of these diets is that there is very little sodium ingestion. Now, this is counterintuitive. You might think that consuming too little sodium should not cause hyponatremia, but it can, and the reason is because the kidneys need some solutes in order to excrete free water. I'll explain this to you in the next few slides. So one of these diets is called the tea and toast diet. This happens when people are trying to lose weight and they eat very little solid food, and as a result they consume very little sodium. In addition, some beer drinkers consume very little sodium. This is called beer potomania, when beer drinkers develop hyponatremia. The reason is because they are getting all their calories from beer and they're not consuming enough sodium. The reason that very little sodium ingestion can lead to hyponatremia is because there is a minimum urine osmolality of about 60 milliosms per kilogram that the kidneys must maintain. This means that the kidneys always have to excrete some solutes with free water, and therefore if you consume very little solutes, in other words very little sodium, that will limit the amount of free water that you can excrete. And then if you intake more free water than the kidneys are capable of excreting, this can lead to hyponatremia. To make this more clear, let's go through the thought experiment I've shown on the screen. So the salt that you consume in your diet must equal the salt excreted. And let's imagine that the highest water to salt ratio that the kidneys can achieve is 10 to 1. In a patient on a normal diet who consumes 3 units of salt, that patient can excrete 30 units of water and still abide by the 10 to 1 ratio required by the kidneys. In a patient on a restricted diet who only consumes 1 unit of salt, they can only excrete 10 units of water. In other words, the water excretion is being limited by the tiny amount of salt in their diet. And this occurs because the kidneys must excrete some salt with water. So if you consume very, very little salt, that can limit the amount of water that you can excrete, and thus you can develop hyponatremia. Here's another way to look at this. A patient eating a normal diet consumes about 1,000 milliosms per day of solute. If the most dilute urine that the kidneys can produce is 50 milliosms per liter, this means the maximum free water output for a patient on a normal diet is 1,000 divided by 50, or 20 liters per day. That is a lot of free water. It is very hard to develop hyponatremia when your kidneys are capable of excreting 20 liters a day of free water. On the other hand, a patient consuming one of these special diets we're talking about now might eat only 250 milliosms a day of solute. Just like normal patients, the most dilute urine for these patients is 50 milliosms per liter. This means the maximum free water output for a patient on a special diet is 250 divided by 50, or 5 liters a day. It now becomes much easier to consume an excess of free water when you can only excrete 5 liters per day. And if the water intake exceeds 5 liters per day, that will lead to hyponatremia. If low sodium in the diet is leading to hyponatremia, the urine will have a low osmolality, less than 100. This indicates the kidneys are working. They are trying to eliminate free water. The problem is they can only get rid of so much free water because they are limited by the small amount of salt. In other words, the small amount of solute availability to go out with the urine. So many textbooks like to divide hyponatremia by the volume status of the patient. So I've done that for you on the slide here. So cirrhosis, heart failure, and some patients with renal failure can be hypervolemic and have signs on physical exam of excess volume like lower extremity edema and crackles and increased jugular venous pressure. Hypovolemic hyponatremia occurs when patients are dehydrated, when they're on diuretics, or where they have primary adrenal disease where they have lost their aldosterone secretion by the adrenal gland. And then euvolemic hyponatremia has a number of causes, including SIADH, which we talked about as a diagnosis of exclusion, also hypothyroidism, secondary adrenal disease, some patients with renal failure, and finally polydipsia and dietary causes of hyponatremia. In patients who have euvolemic hyponatremia, measurement of the urinary osmolality is very helpful. If the urinary osmolality is low, this means the kidneys are responding appropriately and trying to excrete free water. And this is what you see in psychogenic polydipsia and also in the dietary causes like the tea and toast diet and beer potomania. If the urinary osmolality is high, this means the kidneys are not responding appropriately. This can be because the ADH level is high from SIADH or from hypothyroidism, or it can be because the kidneys are failing and they are unable to dilute the urine. In hypovolemic hyponatremia, where patients appear dehydrated on physical exam, measurement of the urinary sodium can be helpful in differentiating the causes. That's because a low urinary sodium will be seen in many of the extrarenal causes of hypovolemic hyponatremia. When patients are vomiting, or they have diarrhea, or they are sweating, in addition to losing water, they lose lots of salt in the fluids in all of these circumstances. This leads to a very low urinary sodium level. On the other hand, if the urinary sodium is high, such as greater than 30, this usually means there is some renal-related cause of the fluid and salt loss. So for example, patients on diuretics can have lots of sodium in the urine because the diuretics block resorption of sodium. Patients who have primary adrenal disease have low aldosterone levels. This also leads to more sodium in the urine. On your exams, you're often asked for the expected changes in ADH levels and urinary osmolality for a given cause of hyponatremia. So all of the disorders I've bolded in red on the screen are associated with increased ADH levels and increased urinary osmolality. In cirrhosis and heart failure, ADH levels are high because of intravascular volume depletion, and this will concentrate the urine and raise the urinary osmolality. In dehydration and diuretic use in patients with primary adrenal disease, the intravascular volume is also low. This raises the ADH level and concentrates the urine. And then finally, in these causes of euvolemic hyponatremia, the ADH level is high, so that also will concentrate the urine. There are just two disorders where the ADH level is low and the urinary osmolality is low. That's polydipsia and the dietary causes. In both of these situations, the kidneys are responding appropriately. They just cannot excrete the free water adequately. And then finally, renal failure is very unusual in that the ADH level is low, but the kidneys are unable to respond by diluting the urine, and thus the urinary osmolality is high. We talked before